Okay, welcome. Good morning, everyone. Happy Mother's Day to all the mothers around the globe. Thank you for joining. Delighted to introduce Dr. Astrid Weins today to speak on minimal change disease Remission. Dr. Weins is an associate pathologist at Brigham and Women's Hospital in Boston and an associate professor of pathology at Harvard Medical School. She's a board-certified pathologist attending on the Brigham Women's Hospital Diagnostic Renal Pathology Service and also directs an active translational research program studying pathomechanism of proteinuria kidney disease. Thank you for being with us today, Astrid, and we look forward to your talk.
Thank you so much for having me today. First of all, happy Mother's Day to everybody and happy Parents' Day for everybody who has children. I think it's a special day. I got a beautiful card this morning from my 5-year-old, and it says, "You I love," which I absolutely love. Anyway, I'm honored to be here today and share some really exciting research we've done. Most of you probably familiar with it already, but it's always fun to talk about it and take everybody through the journey that we've been through to understand this really interesting disease called minimal change disease. And my talk today is entitled Minimal Change Disease Reimagined, because I hope at the end of the talk, you will agree with me that we need to look at this disease in a very different way from what we used to. Okay. So I always start out my talks with a patient who has inspired my research, since I really pride myself and my lab. We pride ourselves in looking at disease pathogenesis inspired by diagnostic observations. We really don't like research that is just, founded in mouse models or cell line observations or your, favorite protein. What we really want to do is understand disease mechanisms coming from the patients and coming from the patient's biopsies and tissues. And this is really how this all started out. This was a 61-year-old Caucasian female. She had a history of congestive heart failure, presented with a 2-month history of worsening edema in spite of increased diuretic treatment. She was on Lasix, like all of those patients are usually. And often these histories are quite long, especially in adults, where they develop this edema, and it is blamed on the heart failure instead of looking at the urine to figure out if maybe this patient might have proteinuria. She also reported a 20-pound weight gain, along with that edema, mild shortness of breath, and she didn't have any macroscopic hematuria. She also had recently suffered from a lower extremity ulcer that is currently healed. So you see there's quite a few reasons, possible reasons why this patient might have kidney disease. She had obviously some kind of vasculopathy with congestive heart failure. She also had an ulcer on her leg, and there might be other reasons too. So on physical examination, she weighed about 250 pounds. She had clear lungs, mild heart murmur, 2+ pitting edema of her lower extremities, and she still had some cellulitis on her lower extremity. She was on the following medications: acetaminophen, vitamin D3, calcium carbonate, spironolactone, and lorazepam. And she had a slightly elevated serum creatinine of 1.5 with a baseline of 1. Low serum albumin of 2, hyperlipidemia, and the urinalysis showed 3+ protein and 1+ blood. And that prompted a spot urine protein over creatinine ratio, which was 14 grams per gram creatinine. So obviously this patient presented with a full nephrotic syndrome, and that in turn then prompted a kidney biopsy. Here's her kidney biopsy. This is a low power overview of one of the cores. You can see here the PAS stained section, and down here is the trichrome stained section. You see she has a background, mild chronic changes, maybe 15 to 20% interstitial fibrosis. You see all this blue. This is all collagen basically in the interstitium. Some of the tubules look mildly dilated, and the glomeruli may be a little enlarged, maybe slight mesangial expansion, but otherwise at this magnification at least, you cannot really see much of anything. When you look at the tubulointerstitial changes, these dilated tubules often also have a flattened epithelium with some nuclear dropout and some vacuolization of the cytoplasm, and we see occasional mitoses. And the PAS stain shows a diffuse loss of the proximal tubular brush border. These are all features of acute tubular injury. And then here's the glomerulus. So one of them, you see some mild mesangial expansion, but other than that, there's really nothing here. There's no hypercellularity. There are no thickened basement membrane spikes or craters on the Jones-Silver stain. So essentially a relatively normal looking glomerulus with no apparent pathology on light microscopy. And then the immunofluorescence slides were delivered to us and we looked at them. And first of all, the albumin was as expected, showing some background staining. This is the glomerulus right here. Background staining of the basement membranes, which we pretty much always see. And then there is some tubular reabsorption of albumin, which you can see in the form of these granules, mostly in the proximal tubules. But then when we received the IgG stain and looked at that, this is what it looked like. It had these very interesting little fine granules, almost vesicular structures. And as you can see here, they were really on the outside of the glomerular capillaries. And the only cell that's really located on the outside of the glomerular capillaries are the podocytes. So, it was really inspiring us that this is some kind of an IgG deposition or at least staining that is seen on the outside of the glomerular capillaries, presumably in or on podocytes. So that's really the finding that sparked this whole query and sort of journey to find out what this IgG staining means and if it might represent an antibody that binds to a podocyte antigen. And then by electron microscopy, in contrast to what we would see in, for example, membranous nephropathy, there are no subepithelial deposits, no subendothelial deposits. The basement membranes are unremarkable. The endothelium is nicely fenestrated and doesn't appear injured. And the only real change, which is quite dramatic, is here the diffuse foot process effacement of the podocytes, which is seen diffusely and globally in all the glomeruli. So overall now, the pathologic diagnosis of this case was a diffuse podocytopathy with minimal glomerular changes, or as we used to call it, minimal change disease, a term that really just says there are no light microscopic changes. And in the old days, before they had immunofluorescence and EM, they would just basically go by the light microscopy, and that's why they called it minimal change disease. There's also some acute tubular injury, which we oftentimes see in almost the majority of cases, especially in older patients, accompanying acute nephrotic syndrome. And then there's some mild chronic changes of the kidney parenchyma in the background. This is the patient's clinical course here. So you can see here the urine protein over creatinine ratio in blue. Later on, they measured urine albumin over creatinine. And then there was a 24-hour urine also done here. And as you can see, she really had a big spike in proteinuria right at the beginning here, then had the biopsy done at the time when she had about 14 grams per gram creatinine. And then after that, she was put on steroids. As you can see here, this is that red bar up here, came down within 40 days to pretty much no residual proteinuria. So she was deemed in full remission. Her creatinine also came down wonderfully at the same time. But then when she was weaned off of the steroids, she acutely relapsed. with about 7 grams of protein in her 24-hour urine collection. And then her steroids were continued, and she received 2 courses of rituximab, an anti-CD20 B-cell depleting therapy on top of that, and then went back into full remission. She has since, I think, had another 1 or 2 relapses. So this patient is, deemed one of those steroid dependent or relapsing forms of minimal change disease. She never had another biopsy, so I don't know if she now has potentially more scarring, but at the time of our biopsy, it was clearly minimal change disease, and we did not see any segmental sclerosis. So really what now is the question that inspired all this research that I'm going to present is, what is the cause of the acute nephrotic syndrome in this patient? And in order to answer this question, we have to first look at what history has taught us. There's a long-standing history of research and case reports in this field, and it goes back over 100 years. And I think it's really, really inspiring and really, really interesting to go look at that history. So we can make an informed decision on what candidates we're going to look at and what really makes sense to look at. So first of all, this disease was not always called minimal change disease. It was initially actually called lipoid nephrosis, because it was characterized by lipid casts in the tubules, because there was so much lipiduria. And essentially, that was what this disease was described as, and that's why it was called lipoid nephrosis. And you might still find that in some very, very old textbooks. And then when it really started to change was sort of in the 1960s. And that's when the first edition of this book, The Pathology of the Kidney by Robert Heptonstall, came out, 1966. So before, the lipoid nephrosis term was based on the assumption that nephrotic syndrome was of tubular origin and had these lipoid casts. But then in 1962, electron microscopy became available and was first introduced to the renal pathology field, or the renal field, by Marilyn Farquhar. And that really recognized this disease as a disease of the podocyte with diffuse foot process effacement. And that led to a proposed change from the term lipoid nephrosis to the podocyte foot process type of idiopathic nephrotic syndrome. And that would have been nice if it had actually stayed like this. Instead, we went to this kind of weird term of minimal change disease. What was also observed at the time already was that there was a progressive sclerosis of the glomeruli starting in the juxtamedullary region of the kidney in some of those patients, eventually coining the term primary FSGS as a form of its progression. So it was clearly deemed to be a progression of minimal change disease to see primary FSGS. Later on, we started separating these two diseases, but originally they were really described as one and the same disease, just as a form of its progression. What is really very important to remember is, and it even says it in this book, that these terms are entirely descriptive of the state of affairs in the kidney at the time of the biopsy. So that's how you really need to see these diseases. That's just showing you what's happening right now in this patient. It doesn't necessarily show you what happened before, and it doesn't necessarily give you an outlook what's going to happen in the future to this patient. So these are stopgap titles. Now the patient has minimal change disease, or now the patient has diffuse foot process effacement with FSGS. But really what we need to do is understand the natural history of this group of diseases, or this disease entity, so we can consider a new name. And then what was really always very clear was that idiopathic nephrotic syndrome has to be caused by a circulating factor. And the evidence pointing to that also dates back quite a long time. In 1954, for example, there was this ethically questionable experiment of administering plasma from nephrotic infants to healthy infants who then develop transient proteinuria. Obviously, that would never be going through IRB approval nowadays, but it's just an interesting observation that again tells you that the factor has to be in the plasma of these nephrotic infants. In 1984, sera from FSGS patients were infused into rats. So this is a passive transfer model of disease, right? That then rapidly developed proteinuria. So again, another hint that this is a factor that is present in the serum of patients who are nephrotic. In 1991, there were several cases reported of maternal fetal transmission of proteinuria, again from the mother to her infant in utero. And in 1994, with the advent of plasmapheresis, it was found that in idiopathic nephrotic syndrome patients, plasmapheresis can, in some of them, decrease proteinuria and leads to partial or full remission in some patients. So again, if you remove this plasma factor, you can cure potentially the disease, or you can at least make the proteinuria better. And in the 2000s now, we have several reports of patients that recurred in the allograft after receiving a renal transplant with massive proteinuria. And if you take these kidneys out of these patients and transplant them again into a patient with a different history, not a history of nephrotic syndrome, then these patients actually do fine with this kidney, and the proteinuria goes away over time. And again, that was with a really nice case report published just last year by a French group describing exactly this scenario. And then we had, several proposed candidates for permeability factors, and not all of them have necessarily been debunked, but I just want to point out that most of these were really not so much associated with minimal change disease, but mostly associated with FSGS and chronic kidney disease. So the most prominent ones among these, probably SUPAR, has garnered quite a bit of attention in the last 10 years or so. Again, there might be a role for this molecule in nephrotic syndrome. There might be a role for this molecule in chronic kidney disease and a variety of other conditions, but it's not clear to me that there is absolute unequivocal evidence that this really causes an early form of FSGS or of nephrotic syndrome. What has also always been clear from the start is that minimal change disease, FSGS, and recurrent FSGS in the allograft, which is really recurrent proteinuria, massive proteinuria nephrotic syndrome in the allograft, it doesn't necessarily start out with FSGS, right? Share common features morphologically, but also with regard to the presence of a possible permeability factor. And this is a milestone paper, which was originally published in The Lancet in 1972 by John Hoyer et al. And it describes 3 patients who had minimal or very mild changes of the glomeruli on biopsy in their native kidney and had nephrotic syndrome, and then went on to progress to renal failure within a few years, and then recurred with acute nephrotic syndrome just very briefly or very shortly after transplantation. And then essentially underwent in the allografts the exact same progression of this disease from a purely looking like minimal change disease type pattern to an FSGS type pattern. And so what they essentially proposed back then, and this paper was actually republished in 2001 by the Journal of the American Society of Nephrology because it was deemed a milestone paper, that they concluded that minimal change disease, FSGS, and recurrent FSGS show similar morphologic features, that they likely share the same cause, and that they likely are caused by the same circulating permeability factor. So that's another thing that was kind of forgotten a little bit over the last few years, where we focused on all these other things that maybe have gotten us off track a little bit in this disease group. But very clearly, this permeability factor supposedly is shared between these three presentations of acute nephrotic syndrome. And then we went into the era of genetics and molecular biology. We learned more about the podocyte itself, its structure, its function, all this intricate network of proteins, some unique to the podocytes, some not unique to the podocytes, that form this very, very tightly regulated, intercalated network of proteins between the slit diaphragm, the actin cytoskeleton, and the focal adhesions and the connection of the podocyte to the glomerular basement membrane. And it also became clear that if you disturb one of those proteins, for example, through familial disease with genetic mutations in nephrin, podocin, actinin 4, foramins, etc., if you see these diseases affect one of those compartments or one of those hubs, the slit diaphragm, the focal adhesion hub, or the cytoskeleton, it actually disturbs all three of those. The whole podocyte is disturbed in its function, is disturbed in its structure if you alter and play with one of those. And mouse models have also led to the same conclusions. So you cannot see one of those compartments in isolation. Really, all of these work together and lead to the changes that we see in a disease that presents with nephrotic syndrome, namely the foot process effacement and the loss of the slit diaphragm structure, and potentially also a loss of adhesion to the basement membrane. So what can we learn from the histology, having looked at all this evidence from the history? Minimal changes, obviously, by light microscopy, diffuse foot process effacement on electron microscopy. And then what's really always forgotten in this whole picture of this disease, of the ultrastructural picture, is that there is loss of the slit diaphragms. And it could look two ways. There's either a loss of slit diaphragms where the podocytes are completely moving apart from each other. And then the other thing, the other observation that's also always very evident in these patients is that some of those are replaced by more of a tight junction looking complex, where it's a very tight connection between the podocytes. So you have both a tight connection in some places and a complete loss of adhesion in other places. And that's very important also to remember, because it really influences the pathophysiology to have both this extreme foot process effacement as well as the loss of the slit diaphragms. And so let's take a look what really happens to the foot processes during foot process effacement. So here you have this nice, normal, healthy kidney glomerulus with interdigitating foot processes that arise from these larger primary and secondary processes. And here you see the podocyte cell body. So you see them sort of enveloping the capillary and forming these interdigitations like fingers, right? Here's a little bit of a schematic that shows this very nicely, how two adjacent podocytes sort of grow into each other, forming these interdigitating connections and increasing the filtration surface, because what's between those fingers is the slit diaphragm, right? When you have foot process effacement in nephrotic syndrome, what you see is not only a simplification of these cell-cell connections, in that all these little finger-like processes or foot processes are being retracted back into the cell body or into the primary processes. And then you have a loss of filtration surface. You have a collapse of the actin cytoskeleton, which goes in, it forms a core, the core of these foot processes. So that is kind of seen as this condensed actin band. And then you also see a loss of foot processes, a loss of slit diaphragm, which is always forgotten in this whole picture of nephrotic syndrome, that you don't only see the foot process effacement, but also the slit diaphragm loss. So can you actually visualize this in kidney biopsies, that this actually happens? Yes, you can. This is a picture that was taken by one of my students many years ago, actually. And this is just an actin staining. And then this is a kidney biopsy from a patient with minimal change disease, acute nephrotic syndrome. And you can see that instead of having these interdigitating foot processes, which you usually would see, now you have these simplified connections, just like in the image that I showed you before, where the podocytes are contacting each other more like regular epithelial cells. And then in some areas, they move completely apart from one another, right? They form these clefts where this is completely open. And you can imagine that water and proteins can, as far as they go through the glomerular basement membrane, can flow freely through these holes. And this is really where the proteinuria occurs. So why is this important, and how does this tie into the pathophysiology of nephrotic syndrome? And this is from this excellent renal pathophysiology book written by Helmut Reinke and Brad Denker, which I can just suggest you read because it's a really beautifully written book. This is a schematic from this book, and you can see here that when you have these podocyte alterations that lead to massive albuminuria, it really goes about with a loss of a small pore system that allows resistance to flow and allows for effective reflection of negatively charged molecules such as albumin by the fenestrated endothelium, which is also negatively charged. So these molecules have the ability to be or can be repelled by the negative charge, but only if there is some resistance to flow and sort of a slow trickling of proteins through these 3 layers of the filtration barrier. And when you take away that final barrier, which is the slit diaphragm, that is enough to basically convert this from a small pore system to a large pore system, together with the effacement of the podocytes in the other areas that forms an increase of filtration pressure. So you have a increase in pressure, and you have an increase of flow through these larger pores. And this is what then makes it impossible for these big proteins like albumin, negatively charged proteins like albumin, to be repelled or held back by the negative surface charge of the endothelium and the GBM. So it really is only that last layer, together with the foot process effacement, that makes this possible. And this is what's underlying the pathophysiology of nephrotic syndrome. You need both the foot process effacement and you need these larger pores between the podocytes to allow for albuminuria to happen. So which slit diaphragm component then is most essential in this whole thing? And what is most essential is nephrin. Nephrin is an essential component of the slit diaphragm complex, and mutations in nephrin, and this is why we know that it's essential, lead to a lack of cell surface localization of this molecule, and then they underlie a disease called congenital nephrotic syndrome of the Finnish type, which you find in infants that are born with diffuse foot process effacement without slit diaphragms and with massive nephrotic syndrome, and they have to be transplanted as soon as possible after birth. So here you see one of those nephrin molecules depicted. They have a very short cytoplasmic tail, they have a transmembrane domain, and then they have a very large extracellular domain here, which consists of a bunch of Ig domains. And these Ig domains cross-link or connect to the nephrin molecule coming from the adjacent podocyte, right? And they form basically this zipper-like structure that we call the slit diaphragm, together with some other proteins, but this is the most essential one that's really essential for the formation of the slit membrane or the slit diaphragm. And then again, in contrast to this congenital nephrotic syndrome, with this established genetic basis, the cause of non-congenital nephrotic syndrome in both children and adults remains largely unknown, as in the patient that I presented at the beginning. And what we also know, which I took you through, is that there's strong evidence supporting a potential causative circulating factor, potentially also immune dysregulation. However, its identity has remained elusive. There's a beautiful study that came out in 1996 by Virginia Savin and her co-authors in the New England Journal, which I ask you, or I suggest to you, you should read. It's a beautiful paper that looks at recurrent FSGS and essentially stops one step short of doing what we did. It found a protein that, as the circulating factor, that binds to protein A, which actually binds IgG, but it fails to identify that protein as a part of a immunoglobulin. So really stops one step short, but really beautiful study in patients with recurrent FSGS. So what therapies work for this disease, and what can we learn from those? So first of all, we know corticosteroids are effective at inducing remission, especially in children. That may be just due to the fact that children are treated much earlier in general, because their moms are not going to wait for 3 months to get the patient back in the office after the biopsy, or they're not going to wait 3 months to have their kid walk around with swollen legs and swollen faces. So this might be why kids respond better, but it's not clear. But you see certain kids and also more adults that relapse, and in which steroid dependence is very common. And in some patients, you need to give additional immunosuppressive agents that are then successfully used, or the patients remain therapy resistant. In the recent few years, B-cell targeted therapies have been increasingly used in this disease, rituximab being one of them, or the most important one. This is an CD20 antibody, and they are effective in both adults and children with relapsing or steroid-dependent nephrotic syndrome, suggesting that there might be a role for B cells with a potential autoantibody-mediated etiology. Patients with steroid-sensitive nephrotic syndrome also show specific changes in B cell subpopulations. If you look at them, they have an increase in circulating early short-lived plasmablasts, for example, which are cells that are known to produce autoantibodies in autoimmune diseases. Further evidence for B cell involvement comes from an observation that is very, very old, that is from the early part of the last century, where kids were hospitalized for nephrotic syndrome and then contracted measles. That was a disease that was incredibly contagious, and there was no vaccine back then. So it kind of like went through all the hospital wards, oftentimes affecting most of the kids that were hospitalized there. And what was found that in these kids that were nephrotic, when they got measles, it essentially cured them for at least for a while. And we now know that the measles virus leads to B cell depletion and immune amnesia. So another, hint that B cells might actually play a very important role in minimal change disease. And here is one of those papers from 1947, the effect of measles on the nephrotic syndrome. So you can see here, those are 2 children with high proteinuria, 4+ proteinuria, and nephrotic syndrome. And then you can see here they contract the measles infection. You see here the fever spiking up. This is when the active infection takes place. And you can see that acute drop in proteinuria within, 10 days in these children, both of those children. And there are several children reported in this paper, which, I suggest you read. It's a very interesting observational study of these children with nephrotic syndrome that contract measles. So essentially, measles act almost like a poor man's rituximab, if you want. I would never say you should inoculate these kids or adults with measles, but it's essentially similar to rituximab because it reduces the numbers of B cells. that produce antibodies. So with that, we are really asking the question, is there other support for nephrin as an antibody target? So if you now put this all together, essentially you want a target that's present on the cell surface that affects the slit diaphragm structure, that is an essential protein. If it gets removed or tampered with, you get nephrotic syndrome. You want this to be an antibody-mediated disease based on all this evidence. It's a humoral circulating factor. It would make all the sense in the world with all the evidence we have that this might be an autoantibody-mediated disease. There's more evidence. Anti-nephrin antibodies have actually been shown to cause massive proteinuria when administered in animal models. So this has been done even not knowing that those were anti-nephrin antibodies to begin with, because somebody just created a whole bunch of monoclonal antibodies against the glomerulus and infused them into rats, and then found that, some of those rats would get very proteinuric and develop edema. And then later on, it was found that this antibody was actually an antibody against nephrin. So a very unbiased study confirming this finding. And then children with congenital nephrotic syndrome of the Finnish type, which I just, talked about earlier, that had these congenital or these mutations in nephrin with complete nephrin deficiency, they can actually develop anti-nephrin alloantibodies following renal transplantation because they've never seen nephrin before, right? And that's accompanied by heavy proteinuria, and it essentially looks like minimal change disease after transplant. And that can happen years after transplant. It does not necessarily happen right away. So another hint that antibodies to nephrin cause nephrotic syndrome. And then, there's also such an interesting precedent from other diseases. And this comes from what really struck me as a parallel was pemphigus vulgaris. Pemphigus is a disease that's a skin blistering disorder. It was found about 10 years ago so they're 10 years ahead of us with all the studies they've done, which is great because we can now go back and kind of follow their map. But these autoantibodies against the desmosomal proteins, desmogleins, which you can see here, which are also interconnecting two cells. They're a junctional protein complex. These desmogleins are attacked by these antibodies that break up the connection between these two desmogleins, and then that leads to skin blistering because the loss of the adhesion of these keratinocytes. So when I saw this little schematic here in this paper that I read, I was really struck by the similarity to the slit diaphragm complex, right? You have two proteins, transmembrane proteins that are cross-linked in the middle, that are forming a junctional complex, that are binding antibodies, and these antibodies break up this connection, lead to endocytosis of this protein, and then these patients develop acantholysis, essentially. And these patients are also, responding to steroids. And if they don't respond to steroids, they get rituximab, and now they actually treat them much sooner or primarily with rituximab, and they do really well with that. Similar, exact same rapid response as we see in minimal change disease patients. So what happens to nephrin and podocytopathies? What you see is, excuse me, a redistribution of nephrin away from the slit diaphragm. And that's been shown in rat models and mouse models of disease as a potential mechanism to explain proteinuria. And then in the actual biopsies, you see when you look at a normal glomerulus versus these are 3 patients from our service with minimal change disease and active nephrotic syndrome, you see that there's not only a rarefaction of the staining of nephrin, but it's also showing this clustering in these little, clusters here that is not really evident in a normal glomerulus. So these two things, again, provided a hint that what we saw in our biopsies may actually be the clustering induced by an autoantibody against nephrin. And I should mention that similar clustering is also seen in pemphigus. So our hypothesis going forward was autoantibodies against nephrin may underlie non-congenital minimal change disease. So we went right for it. We didn't even look at other proteins because we were convinced that if it is an autoantibody, it has to be against nephrin, or at least against a very essential slit diaphragm protein, and there aren't that many. So we developed an indirect ELISA using recombinant affinity purified extracellular domain of human nephrin. So we really thought this can't be the whole nephrin molecule, this can't be an antibody against the intracellular part of nephrin, it has to be the extracellular domain. And a really interesting thing is that IgG is freely filtered, right? You all know it goes through the glomerular filter, so it would hit its target no matter what, right? If a patient has autoantibodies to nephrin, they get filtered and they hit its target. They can't get around it. It's not that it has to diffuse somewhere. It doesn't have to, be endocytosed or anything. It just hits the target and causes the problem. And that was really what we thought would happen, because the onset is so rapid and the response is so rapid, it has to be the extracellular domain of human nephrin that's affected. So here you can see we made this recombinant nephrin extracellular domain. This is a human PLA2R, which is antibodies against which are the cause of the majority of cases of membranous nephropathy, which patients also present with nephrotic syndrome. So we clearly wanted to compare it to another condition to make sure this isn't some non-specific, epiphenomenon of nephrotic syndrome. So here we tested our construct against anti-nephrin commercial antibody. It's nicely recognized. And then human PLA2R is obviously not recognized by that, and vice versa. Serum from a patient that's positive for anti-PLA2R antibodies recognizes the PLA2R, but doesn't recognize nephrin. So we show, at least for these two things, that it is specific to the nephrin extracellular domain. And then we ran the ELISA, and first we used healthy controls, 30 patients from our biobank at Brigham, Mass General. And we took those 30 patients and selected them based on the complete absence of any evidence of autoimmunity, the complete absence of any evidence of kidney disease or any other disease. They're really healthy individuals with no proteinuria. And then we took sera from patients that were known to be anti-PLA2R positive as well. And then we ran the ELISA and we created our threshold based on the highest positive healthy control. And we had to do this because this is not a normally distributed population. So we could not just pick, sort of like the peak of it. We had to really go with the highest positive sample. And then based on that, we tested those 54 patients, sera, from anti-PLA2R positive patients, and only one of them was slightly above the threshold that we created. And that's not necessarily unexpected. It's either that our threshold is too low, or it could be that some patients with membranous nephropathy also have have antibodies against nephrin. There's nothing to be said that this is an exclusive disease, right? We know that patients with lupus have, potentially hundreds of different autoantibodies circulating at a time. So it's totally possible that some patients with membranous also have anti-nephrin antibodies, but there was only one that was slightly above the threshold using this assay. And then we needed to get more sera from nephrotic patients. How do we obtain them? We obtained them from the Nephrotic Syndrome Study Network, Neptune. It's based in Michigan, at the University of Michigan. It's a longitudinal cohort study of patients that basically have nephrotic syndrome or had nephrotic syndrome. They get enrolled and they have these study visits at various time points where they just get a serum sample, they collect a serum sample and urine sample, they take the biopsies and analyze them, take the images, et cetera, and all the clinical data. So it's a nice longitudinal cohort study. And in this cohort study, we found 62 patients that met our criteria of having more than 3 grams per gram of proteinuria at the time of the earliest study visit. So we wanted early patients. We didn't want to have patients that were already down the road too long. We really wanted patients with biopsy-proven minimal change disease. We did not look at FSGS in this cohort because we wanted to have a population with the least amount of confounders possible. We also picked patients that had no known Mendelian nephrotic syndrome variants. So everything that's known, which we went through before and more, these patients did not have. So we ended up with 62 patients, 66% children and 34% of adults. And we ran those all in our ELISA. What I should point out now is that 97% of those patients, 60 of those 62, were actually already treated prior to this assay. So that's the problem with the study, that patients get enrolled after diagnosis. They usually are already started treatment or have a somewhat complicated clinical course. So it may be that what we found in this cohort is actually underestimating the true incidence of this antibody positivity in minimal change disease, because the patients already were on immunosuppressive treatment, some of them on multiple agents. So what we found was, applying our ELISA from before, that out of these 62, 18 were clearly above the threshold, some of them high above the threshold. And that amounted to 29% of this study population. Given all these things that I just told you, these caveats, a lot of these patients were already pre-treated. They may not have been in active full nephrotic syndrome anymore, even though they had high proteinuria. So these are all things that we need to take into account when thinking about this number, that potentially we're looking at a much higher number of positive patients when we look at the right time point under therapy naive conditions. And then we were also curious what happens in patients in which a subsequent serum sample was available during either partial or complete remission. And what we observed was essentially a significant reduction or complete absence of Nephrin autoantibodies in all of those patients that we found meeting these criteria. And then we also, this is the ELISA results. You see here in blue, the active sample, in red, the remission sample. And then also here, we repeated this whole thing doing an immunoprecipitation experiment where we took we took the serum of the patient, mixed it with the nephrin extracellular domain that we created, and then ran everything over a protein G column, and then eluted the fraction that bound to the protein G, which should be IgG. This is the IgG we eluted, and then this is the nephrin Western blot in that population. So clearly, nephrin is, so you basically run it on a, you run it on a Western blot. The Western blot contains human glomerular extract from patients, and so this is what you find. So similarly, only serum obtained during an active disease or partial remission immunoprecipitated nephrin from healthy donor kidney derived human glomerular extract. So we could confirm these results using another methodology to see if these patients had anti-nephrin antibodies only in active disease, but not in remission, which actually confirms one of Koch's postulates that a disease-causing factor has to be absent in disease remission and present in active disease. So is there IgG anywhere in minimal change disease biopsies? Obviously, the findings we had in a serum were hard to reconcile with the traditional view of minimal change disease lacking IgG deposition, not being an IgG immune complex deposition disease. So while podocyte-associated IgG can be observed in minimal change disease, as I showed you before, it is often really minimal when compared to membranous nephropathy, for example. And in the absence of those visible electron-dense deposits by electron microscopy, it is generally attributed to non-specific protein resorption with little significance. So obviously, this has been observed, but it hasn't been paid attention to. And so therefore we turn to our own archived biopsy samples to actually evaluate them for presence of IgG in the patient tissue. And we didn't really have to do much work on this because we in our institution have reported every single time we saw this IgG subtle staining in our biopsies for over 15 years. So we can go back 15 years and we will find reports where it says there's fine dusting for IgG over the podocyte compartment. So we did that, and it turns out in our institution at the Brigham, between 4 or 5 different renal pathologists, we have about 60 to 70% of all minimal change disease cases that have this feature. So obviously, if this truly represents anti-nephrin antibodies, the number, the incidence of IgG in the biopsy is much higher than just 29%, as we found in the study population that we evaluated for circulating antibodies. So again, here's this feature, the delicate extracapillary punctate and diffuse glomerular staining for IgG. You see it can be kind of subtle. If you have, non-optimal IF, or if you just do immunohistochemistry, peroxidase staining in your cases, you will not pick this up. This is really something that can be incredibly subtle. This is probably one of the stronger cases here because I just selected that because I can show it better. But it even doesn't translate very well on pictures sometimes. You have to really look at it yourself and then you see it. And it's very, very subtle compared to what we see in membranous, where you see these prominent IgG immune complexes. And obviously, these are associated with true immune complex deposits. So what did we do to convince ourselves that this was not some nonspecific stuff, that this is really an immunoglobulin that's being deposited? Well, it turns out it's not only the IgG heavy chain that stains, it also stains for kappa and lambda. So it's a whole immunoglobulin. And it also stains for different IgG subtypes. Most patients, though, have a predominance of IgG4 or IgG1. So that's similar to what has been observed in, for example, membranous nephropathy and other autoimmune diseases, where IgG4 seems to be mostly the predominant subtype for IgG. But it's a polyclonal full immunoglobulin. It's seen with different antibodies. So this is not some antibody, non-specific phenomenon. And then next, obviously, wanted to know, does it have a specific target? Does it actually co-localize with nephrin, which would be another thing that we would want to see? And indeed, compared to a normal biopsy here, a minimal change disease patient who's positive for this IgG dusting that we saw also had nephrin in a similar distribution pattern. And you can see how they co-localized as part of these yellow little vesicles or yellow little structures. So it's yellow, the yellow shows co-localization. Clearly it's there in patients that are positive for this dusting. Clearly it's not co-localizing with nephrin in patients that do not have the dusting. And what you see here is essentially just the background staining of the glomerular basement membranes. And in membranous nephropathy, there's also no substantial overlap between immune complexes and the nephrin, because they are not really located at the slit diaphragm. They're located at the base of the foot processes. And then we also observed several patterns. So the most important ones were these two. We saw this sort of like ramen noodle appearance that was used by someone in some talk that I gave. They asked if this was a ramen noodle appearance. I think it's really a beautiful description of this. It actually really kind of shows this kind of wiggly pattern. And you can now see when you remember back the picture of the ultrastructure of phase podocytes, that these wiggly lines are just the two podocytes meeting each other. So here it's probably still present at the junction, whereas in other cases, it's already been removed and endocytosed potentially into the podocyte, or it's removed or moved further apically into the podocyte. And so here it's more of a punctate or a vesicular pattern, whereas here it's kind of still binding to close to the slit diaphragm complex. So, and then obviously we wanted to see in our own patients that had this feature, could we see the antibody in circulation at the time of the biopsy when we saw this feature in the biopsy? So we wanted to obtain serum during active disease in these patients that had a kidney biopsy done in our institution or in some collaborators' institutions. So we found 9 patients that were IgG positive, on which we were able to just grab the serum samples, the time of the biopsy, and here's what we found. All of those 9 were positive for anti-nephrin antibodies in the serum, whereas all of them that were negative did not have it. So this is really interesting that the positivity in the serum correlates with the tissue staining or presence of the antibody in the tissue. And this is what we expected, and we were happy to see this. And then we also corroborated these findings with an IP using human glomerular extract, and we also corroborated this finding with an IP using just nephrin extracellular domain and incubating that with the serum and running it on a Western blot. So this is what we found. And then 4 of those 9 patients, including the patient that I initially showed you, which is this patient number 3 down here, all of these 4 patients also had a follow-up sample, which we could obtain in complete remission. So there are 4 patients all going into complete remission, some requiring only steroids, some requiring steroids plus rituximab, but they all reached remission. We got a sample in remission, and they all found had a significant reduction in antibody titers concordant with treatment response, and those findings were also corroborated by IP. So clearly, in minimal change disease, I think we nailed down the presence of these antibodies. We have an idea of how they potentially cause the disease, although we haven't proved causality yet, but hopefully we'll do that in the coming, months or years. But how about FSGS? I told you all the story in the beginning about how this is all the same disease. So do we find those antibodies in FSGS? And it turns out, yes, we do find them in primary FSGS, not in as many cases as minimal change disease. Let's see, here we have 60% in this study. This is from a couple of years ago where we kind of like just made a little inventory of our cases. I recently did one from just the 2 last years. And what I found was about 65% positivity in minimal change disease and about 35% positivity in primary FSGS. And interestingly, most of the cases that we found positive were actually tip lesion variants or cases that showed collapsing features, which would actually make sense because those are probably early and acute presentations rather than, advanced FSGS where you just have a scarring stage. Obviously, in those cases, even though they have a history of nephrotic syndrome in the past, maybe you won't find that antibody at that point any longer. And the proteinuria may have a secondary cause due to the podocyte failure. And then this is a nice case, which is a patient that initially presented with minimal change disease. Here's the clinical course. He was not compliant with his prednisone, and then several months later showed up again at a different hospital where he received another biopsy. And this shows a beautiful progression from minimal change disease-like pattern to a collapsing glomerulopathy type pattern. And this is, he was tested for APOL1 risk alleles. He was negative, so this is not an APOL1 driven collapsing glomerulopathy. This is probably just very severe podocyte injury or another genetic underlying factor that leads to this progression. But he was positive both at the time of initial presentation in the biopsy with the fine dusting. You can hardly see it here, it's so small. But again, also positive at the second biopsy, and the EM shows virtually indistinguishable features of diffuse foot process effacement and loss of slit diaphragms. And here's the IP with the positive nephrin test, and here's the ELISA, same. So this patient clearly shows positivity even at the time of what you would call sort of maybe a cellular variant, a collapsing variant of FSGS. And this is another patient with an early form of kind of a tip lesion, FSGS. You see the albumin granules here. You see the IgG staining here. These are obviously your absorption granules that are staining. But here you see this fine granular dusting, which is diffuse, right? So this is distinct from these reabsorption granules. And that's very important to remember. Reabsorption granules are usually like bigger, very coarse, and they have this very clean outline, whereas this dusting is sort of like in the background and it's diffuse. It's not only seen in some segments. And again, if you do the IgG nephrin staining, the reabsorption granules are negative for nephrin, but the dusting is positive for nephrin. So clearly there's overlap here. This is the diffuse foot process effacement. You see some podocytes moving apart from each other, forming these clefts. Here's the clinical course. And here's the nephrin antibody test, positive at time of biopsy, negative 7 months later when the patient was in complete remission, just with steroids alone. So clearly this is another case where you can see it in early primary FSGS clearly present here, and not only in minimal change disease. And again, in disease recurrence, just in line with all the studies that have been done before, in patients with recurrent FSGS by Virginia Savin, where she also thought there must be a permeability factor, but didn't realize it was a full immunoglobulin, but she called it an immunoglobulin-like factor. This is a patient who had childhood onset steroid-dependent minimal change disease or nephrotic syndrome. Then there was no underlying genetic basis found. Then she progressed to FSGS and end-stage kidney disease, required transplantations, got her transplant, and recurred in the transplant with incredibly high proteinuria. Unfortunately, no biopsy was done because in her case, they treated her with plasmapheresis and rituximab, and she responded beautifully. And you can see here the circulating anti-nephrin titers before the transplant. And this was over a year before the transplant because we had to get her HLA lab samples for this. They didn't collect a sample right before the transplant. And then when she recurred, at the time of recurrence, we looked at the plasmapheresis fluid, which was positive. And then obviously later on, the samples were slightly positive, but below our threshold. And then when she was in complete remission, a year out, under no rituximab treatment and just your conventional immunosuppressive therapy, she was completely negative for anti-nephrin antibody and remained in sustained remission. And we have since now tested several other patients with recurrent disease where we find positivity for anti-nephrin antibodies clearly associated with active recurrence. Even if the recurrence happens later on in the course of the transplant, that's where it's positive, and it's not positive when the patients do not recur. So very clear association. There are some patients where we do not see anti-nephrin antibodies in recurrence. That could have one of two reasons. One, it's a different antibody or a different circulating factor causing it, or it is not present in circulation at the time because it's all bound in the kidney, in the transplanted kidney. So we don't know that. More studies need to be done to determine this. These are some other samples. This is from a collaborator in France. They were all collected the day of the transplant, as far as I know. These 4 patients are clearly positive, whereas some others are clearly negative, and this is our positive and negative control here. So clearly you can find it in recurrent disease, and I'm postulating that it likely is also the responsible circulating factor causing disease recurrence in the allograft. So again, in summary, we hypothesized that anti-nephrin antibodies could play a role in the pathogenesis of acute podocytopathies. We started out looking just at minimal change disease because it's just the cleanest subset of patients with not so many other confounding factors. We discovered specific circulating autoantibodies against nephrin in these patients, both podocyte bound, but also in circulation. We introduced this new serological assay that we can use to measure anti-nephrin antibodies in patient serum. And I'm hoping this will come to the clinic very soon so that you or everybody else can order this assay just like you order anti-PLA2R antibodies now. The presence of anti-nephrin antibodies correlates with disease activity. It can also be used as a disease monitoring or disease, response to the therapy response biomarker, if you want. We found subtle IgG also in kidney biopsies that co-localizes with nephrin, further corroborating our hypothesis that this is indeed the disease-causing factor. Our studies shed light on the etiology of a severe disease that has been poorly understood for decades and provides a framework for defining a subset of nephrotic syndrome as an autoimmune disease. And it's an organ-specific, antibody-mediated, potentially functional antibody-mediated autoimmune disease, not an immune complex deposition disease, as we see in other forms of kidney disease or glomerulonephritides. And so, again, just as a last thing, pigeonholing in this disease is extremely problematic. I stole this term from my mentor, Dr. Helmut Ranke, who uses this a lot. We have a tendency in pathology to try to find a box for everything. We cannot find a box for this. We need to look at this from a pathogenetic, and from a pathomechanistic standpoint. And that's why it's so important to understand this disease, find a circulating factor, and really look into how this disease develops and what other factors might play a role, genetic and or other circulating factors that work together with anti-nephrin antibodies to really cause disease progression and therapy resistance. And I think this is just what I'm going to leave you with. We're out of time, but it's just a very, very important thing to understand the cause of a disease. We should never stop at just treating a morphologic description. And I'm going to stop here. And this is my team. Really key people on this paper are these three individuals, Andy Watts and Keith Keller, the two shared first authors. Keith always gets forgotten because he's the second on the paper, but they are shared first authors and they did both amazing work on this project. Keith did most of the stainings and helped with the Western blots. Andy did the ELISA optimization and a lot of the IPs and really was very much involved in writing the paper. He's a very careful scientist, and it was great running things by him. When I'm sometimes jumping to conclusions too fast, and he always holds me back, and that's a good thing for your scientific team. And then Helmut Ranke, without whom I would have never done this project, because he's the one who observed this IgG pattern. He's the one who encouraged me to look what this might be. And I remember when we first found the circulating factor, or when we first found the anti-nephrin antibodies on a Western blot, just a plain old Western blot, where we ran, human glomerular extract and just incubated it with the patient's serum and had a band the size of nephrin. I remember us all jumping in his office because we couldn't believe that we found this. And these are a lot of collaborators without whom this project would have not been successful. Thank you very much for your attention, and happy to take some questions if we even have some time left. Thank you so much.
Wow, congratulations, Dr. Weins. You basically rewrote the chapter in minimal change disease FSGS. So congratulations for the work and the legacy. Fantastic. There are a few questions. Let me open here that so people can unmute and post them, and I can also forward a few questions to you. But all those years, at least since the inception of the first time when I saw the study, it was like, how come like what, nephrin now, antibody, and we have been doing immunofluorescence for a few decades now. How come no one really followed it? And you mentioning running patient serum against Western blot of glomerular extract. It can't be the first time having been done. Yeah, can you just briefly tell that before we go?
Yeah. Well, Couple things. First of all, people never thought of this being possible, that this is an autoantibody, because we're so used to seeing these immune complex deposition diseases that all we think is if we don't see it in the biopsy, it can't be an antibody, which is completely crazy because there's so many other autoimmune diseases that are functional interference autoimmune diseases, myasthenia gravis, pemphigus, for example, other ones where you don't necessarily see the autoantibody if you don't look carefully. But so I think we need to just get away from this concept of immune complex deposition disease being the only form of autoantibody-mediated disease in the kidney. Obviously, TMA is another thing. There's so many things that are caused by autoantibodies where you can't see them. So this is the first crazy thing. And so I think people didn't really look in minimal change disease. The other thing is minimal change disease was like benign, nobody did a lot of research on it because minimal change disease, well, they mostly respond to corticosteroids and what are we going to, it's fine, it works, why should we care? And then people focused a lot on FSGS, and there the problematic thing is that FSGS can be in various stages of activity and people don't necessarily they just lump them all together. They don't necessarily separate them out by active disease versus not active disease. And then the last thing is that, people came very close. Virginia Savin came very close, but because when she did her Western blot and found a 50 kilodalton protein, she likely just identified the heavy chain of the antibody because the antibody is made up of different proteins, right? It's not just one. And so that's why she didn't look further down if there's only also a 25 kilodalton fragment, which would be light chain, right? So you wouldn't necessarily find the antibody if you don't know what the target is. So I think that knowing the target and having this informed sort of approach to it was key to finding it.
Great. So I'm going to pass on the few questions from the chat in reverse chronology, just because it's easier. So the last one here, anti-nephrin in lupus podocytopathy. Have you looked, or is that something to consider?
Well, it's not something we see a lot of. I think I have a couple cases that are positive and a couple cases that are negative, where we thought it was lupus podocytopathy or hypothesized it, and we didn't find evidence for anti-nephrin antibodies in some of them. So we see this dusting pattern in some of those cases, and I believe that those are probably anti-nephrin antibody mediated. And there's no reason why lupus patients shouldn't also have anti-nephrin antibodies. So absolutely.
Okay, and then lumping here two questions together. Is it possible that some of the minimal change disease presentations are due to antibodies targeted to different antigens than the nephrin, and would there be a role for mass spec to identifying those antibody antigens?
Yeah. So it's absolutely possible. Of course, everything is possible. But I think, there aren't many antigens in that little compartment of the slit diaphragm that are possible antigens for antibody binding and that have this kind of presentation. You could argue there's NEF123, there are other proteins in that area. Podocin's probably not likely because it's intracellular. And so these things could be targets. They're so similar to nephrin that it's almost, if they're a target, then nephrin would be a target as well. So maybe it doesn't even matter. Mass spectrometry, yes, we can. This is a great technique that we can use in membranous nephropathy because we have massive amounts of antigen there, right? In this disease, we don't have massive amounts of antigen, so it might not actually work. You may not have enough of it to find it. So because it gets removed, the nephrin gets removed. We have cases where we literally see almost no nephrin left, and there's a few little dots that co-localize with IgG and the rest is gone. So if you were to do mass spec, you wouldn't actually find nephrin because nephrin is not necessarily left there, right? Or in just very small quantities. So I think mass spec is not really a good approach for this disease.
Okay. Here, Let me see, what do we have else? And I encourage folks to unmute if they have any questions to bring forward. The correlation of the serum titers versus disease activity, and also probably the issue of sensitivity and specificity of the serology. Is that something you can comment on?
So what I can tell you is that literally in every case we see the dusting that we were able to get our hands on serum, and that's not the case for every patient, because a lot of our patients come from the outside, from small practices, and we don't necessarily get serum from those. But in all of them where we saw the dusting, we also saw circulating antibodies. I don't know about patients, if there are patients that have anti-nephrin circulating antibodies but no dusting. I can't think of a case that I've seen, but it's possible. It's possible maybe in the transplant setting, where you have a really, you have to think of it as an antibody storm. Those antibodies have built up before in the patient and then just hit that new kidney and remove all the nephrin. So there might be a scenario where you do a biopsy and you don't see anything because all the nephrin's gone, but you have still circulating antibodies. That needs to be determined. We don't know the answers to that. In terms of specificity, I showed you the data on the PLA2R sera. There was one case that was positive. It's hard to see it. If it could be that patient had both, minimal change disease and membranous. There are patients with membranous with very few deposits that have diffuse foot process effacement. It's possible they will also have anti-nephrin antibodies. I do not know. We have to do some more studies to figure that out.
Excellent, thank you. And maybe the last question, and you alluded to at the very end of your talk, is the commercial availability of the serology. In clinic, particularly in the adult patient population presenting with nephrotic syndrome, if we now also have an antibody for minimal change / FSGS, that would maybe spare a many fuse kidney biopsy. What is the timeline for that?
I wish I knew. I hope soon. We are in conversations with a company in Europe that wants to take it on. We also in conversations with other labs to bring it on. I think it's going to happen in the next 6 to 12 months. I'm hoping it'll be a panel that you're testing for, for every patient with nephrotic syndrome gets a panel of antibodies tested. That's sort of my look into the future. I think it's also really important for kids that don't get biopsies. I think it means so much for parents to know what their kids have and not only treat it with some crazy immunosuppression. Maybe they don't need as much immunosuppression. Maybe a few weeks of steroids be enough and you can monitor the antibodies going down. Maybe we can even have a test for autoreactive B cells at some point. I don't know. But this might be, somewhere to go. And hopefully it should be changing the way we look at these diseases and diagnose these diseases.
Okay, wonderful. Okay, with that, we conclude. Happy Mother's Day again to you, Astrid. Thank you so much for being with us today, and everyone for joining. Phenomenal talk. Thank you for inspiring us.
Thank you so much for having me. You too. Bye-bye. Happy Mother's Day.